This is the fourth and last video in this short series on fungal diseases, and our topic today is antifungal medications. The learning objectives are to be able to list the three major classes of antifungals and at least three members of each class, to describe the mechanism of action of each antifungal class, to list common toxicities and side effects of specific antifungals, and to be able to choose an appropriate antifungal in a patient with a suspected fungal infection. When watching this video, please keep in mind that new antifungals are being developed, guidelines get updated, and resistance patterns change and also vary across different parts of the world. So please do not use this as a reference during direct patient care. Always consult up-to-date guidelines or an infectious disease expert when selecting an antifungal for an ill patient. So what are the classes of antifungals that are out there? To understand how the classes differ from one another, I'm going to bring back this figure from earlier in the series. This is a cross-section of a typical fungal cell wall and membrane. The three main antifungal classes each exploit a component of the cell membrane or wall which is unique to fungi, thus allowing the drug to avoid targeting our own cells. Polyenes are a class of compounds derived from Streptomyces bacteria. They bind to ergosterol, which, if you recall, fungi use in place of cholesterol. Once a polyene has bound to ergosterol, it induces the development of pores in the membrane, allowing disruption in the electrochemical gradients. Azoles inhibit an enzyme called lanosterol 14-alpha demethylase, which is necessary for ergosterol synthesis. Last, echinocandins inhibit beta-1,3-glucan synthase, which, as you likely guessed, is necessary for the synthesis of beta-1,3-glucan, a necessary component of the fungal cell wall. Because some of these class names may sound unfamiliar, yet you have probably heard of specific members of each, let me just mention a few to help everyone get on the same page with what drugs we're talking about. So the main member of the polyenes is amphotericin, known more completely as amphotericin B deoxycholate. As I'll talk about in a few minutes, there are several additional forms of amphotericin, one called liposomal amphotericin B or ambisome, and another called amphotericin B lipid complex or abelset. I'm not going to discuss it at all in this video, but nystatin, used for superficial and mucocutaneous candidal infections, is also a polyene, and in fact has a chemical structure almost identical to that of amphotericin. I think that surprises most people since, as I'll discuss, amphotericin is one of the most toxic of all antimicrobial agents, yet nystatin is used all the time without concern and without really much thought given to its toxicity. But the explanation is actually quite simple. Nystatin is minimally toxic when given topically, but is never given intravenously because it's even more toxic intravenously than amphotericin. Moving on, commonly used azoles include fluconazole, itraconazole, and voriconazole, along with a few others that are a little less common. And the echinocandins include caspofungin, micafungin, and the fundaceae anadulafungin. Amphotericin B. Originally isolated from the bacteria Streptomyces nodosus in 1955, if curious, there is a compound called amphotericin A, which is identical to amphotericin B with the exception of one of the latter's double bonds being converted to a single bond. But amphotericin A has substantially less in vivo antifungal activity and is literally never used clinically. Amphotericin B, on the other hand, has an extremely broad spectrum of antifungal activity, being active against most Candida species, Cryptococcus, most Aspergillus species, Mucorales, and the classic dimorphic fungi. Resistance to amphotericin is pretty uncommon and is generally only seen in Candida lusitaniae, Aspergillus terreus, Scedosporium species, and Fusarium species. If you're scratching your head wondering what in the world those fungi are, they are very uncommon pathogens. In 10 years, I've never seen a single case of any of them. However, they are generally recognized as emerging pathogens, particularly in immunocompromised hosts, that we might be seeing more of in the decades to come. An historical, interesting side note is that Aspergillus terreus was the original source of lovastatin, the first member of the critically important cholesterol-lowering medications called statins. Aside from those very rare resistant pathogens, there is a much more significant problem with amphotericin: its toxicity. In fact, toxicity of conventional amphotericin, that is amphotericin B-deoxycholate, is great enough that its use is generally reserved for life-threatening infections when there are no other reasonable alternatives. What are those toxicities? The most significant one is nephrotoxicity, which is common and usually reversible. Risk of overt renal failure is higher with dehydration and concurrent use of other nephrotoxic drugs. Other common toxicities include a relatively common and unpleasant infusion reaction, electrolyte disorders, particularly hypokalemia and hypomagnesemia, phlebitis, and a somewhat lesser issue than the other toxicities, a reversible normocytic anemia. Because of the combination of its high effectiveness, broad spectrum of activity, and substantial toxicity, there's been a lot of work done to develop less toxic formulations of amphotericin, specifically a group of drugs collectively called lipid-based amphotericin B. Nephrotoxicity is lower with these drugs, but they are also more expensive, and whether or not they are cost-effective remains an open question. There are two common lipid-based formulations. One is formally called liposomal amphotericin B, which goes by the brand name Ambisome. That annoying capital B in the middle of the name is actually part of the brand. Another formulation is amphotericin B lipid complex, which is sold under the name Abelset. There's a third one which is not as common as the others, at least not in my experience, called amphotericin B colloidal dispersion, and marketed under the trade name Amphotech. The structure of these lipid-based formulations are worth discussing just for a few moments because they're very fascinating. Ambisome delivers amphotericin within artificially constructed spherical structures called liposomes. Liposomes are composed of a phospholipid bilayer and is sort of like an artificial cell membrane lacking any internal structure or contents. And the amphotericin molecules sit within the bilayer. The structure of Abelset is a bit more complicated. In this drug, the amphotericin is complexed with two different phospholipids into this relatively small rosette-type arrangement, and the smaller complexes aggregate into very large ribbon-like structures. It's generally thought that the explanation for the lower toxicity of lipid-based formulations is that the amphotericin is not released until these superstructures interact directly with the fungal cell wall and/or membrane. I'll next discuss the azoles. To remind you, these inhibit synthesis of ergosterol. The most commonly prescribed of these drugs are fluconazole, itraconazole, and voriconazole. Some less commonly prescribed members include posaconazole, ketoconazole, clotrimazole, and miconazole. Unlike the various forms of amphotericin and the echinocandins, the azoles exhibit substantial differences in spectrum of activity between different drugs. I'm going to go through the activity and common use for fluconazole, itraconazole, and voriconazole in a somewhat crowded and information-dense chart, but I'll then summarize it with the most important 4 points. So starting with fluconazole, this is the first-line agent for most infections with C. albicans, including candidemia, provided that the patient is not neutropenic, they haven't recently received azole therapy, and the hospital has relatively low rates of fluconazole resistance among Candida isolates. Using Candida glabrata as an example of just one of the non-albicans Candida species, fluconazole is generally not recommended while sensitivity testing is pending due to the relatively high rates of fluconazole resistance. For Cryptococcus, it's considered to be first line for mild non-CNS disease. For cryptococcal meningitis, it is used for consolidation therapy after initial response to a combination of amphotericin and an antifungal called flucytosine. I won't otherwise be talking about flucytosine, which is rarely used, typically only for this specific indication and which is profoundly expensive. Fluconazole is ineffective against both Aspergillus and Mucorales. It is a second-line treatment for blasto and histo, but considered to be first-line therapy for mild to moderate cocci infections. How does itraconazole compare? It is not recommended for systemic infections with Candida albicans. It is apparently occasionally used for mucocutaneous infections, though I've never personally seen that. As with fluconazole, it is not recommended for Candida glabrata infections. For Cryptococcus, it can be used as a second-line agent for mild non-CNS disease. For Aspergillus, it is only a third-line agent for invasive disease, but more commonly used in combination with steroids in allergic bronchopulmonary aspergillosis and occasionally in allergic fungal sinusitis. It's ineffective against mucorales, but is a first-line choice in mild to moderate infections of blasto, histo, and cocci. With voriconazole, it can be used for Candida albicans, but it's unclear if it offers any benefit over fluconazole. As with fluconazole, not recommended for treatment of C. glabrata while sensitivities are pending. The data for use of vori against Cryptococcus is too limited to offer recommendation. The key role of voriconazole in modern medicine is as the first-line agent against invasive Aspergillus infections, when it is sometimes used in combination with an echinocandin. Regarding mucorales, as with fluconazole and itraconazole, vori is also ineffective. For blasto, it can be used for CNS disease as step-down therapy after initial response to amphotericin, but there doesn't seem to be much experience with it in infections caused by histo and cocci. So that's a lot of information about azole and indications. Let me summarize the key indications for each azole. Fluconazole is first line for most stable patients with candidemia from C. albicans, as well as most primary cocci infections of mild to moderate severity. Itraconazole is used primarily against the dimorphic fungi. Voriconazole is the treatment of choice against invasive Aspergillus with or without a concurrent echinocandin. And last, none of the three are appropriate choices for empiric treatment of C. glabrata infections or mucormycosis. Although they are better tolerated than amphotericin, the azoles also have a bunch of toxicities. Common to all of them are hepatotoxicity and numerous drug-drug interactions. The most notable of those interactions are with Coumadin, which results in a substantial increase in INR, rifampin, and most anti-seizure medications. Then there are some drug-specific effects. For example, fluconazole causes alopecia, itraconazole causes an unusual combination of hypertension, hypokalemia, and edema, and voriconazole is associated with neurotoxicity, visual changes, and photosensitivity. There is one additional important note about these drugs, specifically fluconazole. Although I only listed one non-albicans species of Candida, there are certainly many other lesser-known ones, including Candida krusei. All Candida krusei is intrinsically resistant to fluconazole. Fluke should never be used against this specific pathogen. Now, as mentioned earlier, there are a good dozen or so additional azoles. In the US, I've only come across 4 others. There is posaconazole, which is notable as the only azole with clinical activity against mucorales, though it is generally only used in mucormycosis as step-down therapy after initial improvement with amphotericin. Ketoconazole, which is primarily used topically for superficial infections and generally not used for systemic infections. Something unique about ketoconazole is that it has anti-androgen activity and is therefore occasionally used in advanced prostate cancer. And the 2 azoles, clotrimazole and miconazole, which are primarily used for treatment of superficial and mucocutaneous infections. The last major class of antifungal to discuss are the echinocandins. To remind you, these inhibit beta-1,3-glucan synthase. This results in cell lysis with Candidal species, that is, it is fungicidal against Candida, while it simply inhibits the growth of Aspergillus or is fungistatic. The 3 members of this class, caspofungin, mycofungin, and anadulafungin, are structurally similar. They are cyclic hexapeptides and all have poor oral bioavailability and therefore must be given intravenously. Conveniently, at least while trying to learn these drugs, they all have the same spectrum of activity. Their most common clinical uses include empiric therapy in suspected candidal infections in those situations in which azoles are contraindicated, such as neutropenia, clinical instability, and recent azole use. and as a second-line agent in invasive aspergillosis, or in combination with voriconazole in invasive aspergillosis. The echinocandins have minimal activity against mucorales and the dimorphic fungi. Significant side effects and drug-drug interactions are both relatively uncommon, and their major disadvantage of the echinocandins, they are very expensive. Here's a summary of the antifungal coverage of the medications discussed in this video. Please keep in mind, on account of it being a summary of complicated information that's not easily summarizable, there are going to be some minor details not accounted for. I'm going to make one new point before moving on. So far in this video, I've considered just two Candidal species, Candida albicans, which is by far the most common, and Candida glabrata, which is a non-languageable minority of Candidal isolates. But as discussed in some of the previous videos, there are other Candidal species. Also, resistance patterns, even among albicans and glabrata, are becoming less predictable. Therefore, some ID experts recommend not even thinking about antifungal coverage in terms of specific Candidal species, but rather approach Candidal isolates solely in terms of their sensitivity profiles. This is obviously a summary of the pharmacology, toxicities, side effects, and relative costs of these drugs. Once again, I'm not going to read through it line by line. I will, however, just point out in the cost column that none of these drugs get a single dollar sign. That's because no antifungal medications, at least no systemic antifungals, are particularly cheap. As you can see, the most expensive are the lipid-based formulations of amphotericin B and the echinocandins. I'll end the video with an overview of an approach to suspected candidemia. First, why might a patient be suspected to have candidemia? One situation would be the presence of suspected systemic infection with persistent fevers despite broad-spectrum antibacterials. The most common situations in which to see this is in a patient presenting with non-resolving neutropenic fever, or in a patient in the ICU for some other reason who develops severe sepsis while in the hospital and a bacterial source cannot be found. Another situation in which you should suspect candidemia would be if Candida is isolated from both respiratory and urine cultures at the same time. While most positive sputum cultures with Candida and most positive urine cultures with Candida do not represent pathologic infection, if both sites are growing Candida at the same time, that should make you wonder a bit more. Also, in all these situations, consider the risk factors for candidemia. This is not a complete list, but major risk factors include immunosuppression, particularly organ transplantation, chemotherapy, and advanced AIDS, older age, an indwelling central line, recent antibiotic use, TPN or total parenteral nutrition, recent abdominal surgery, renal failure, recent PPI or proton pump inhibitor therapy, and chronic steroid use. So once you've reached the decision that you suspect candidemia, you should remove or exchange all catheters, both intravenous catheters and urinary catheters. And also obtain a formal ophthalmological exam looking for secondary fungal endophthalmitis. In common practice, doctors wait until candidemia is confirmed before requesting an eye exam, but given the relatively low sensitivity of cultures for candidemia, the more prudent approach is probably to request it as soon as a fungal infection is suspected. Then, of course, you should also start treatment empirically. As far as I can tell, there is no specific standard of care regarding choice of empiric antifungal, but this approach that I'm going to present is consistent with a handful of articles in the literature and also seems consistent with the practice of most local infectious disease experts. Ask if any of the following are true. Is the patient neutropenic? Are they clinically unstable? Have they recently received azole therapy? Or does the hospital have relatively high rates of azole resistance among Candida isolates? If the answer to all of those is no, then start fluconazole. If any of them are a yes, start an echinocandin or lipid-based amphotericin B. Some sources make a mild recommendation of the echinocandin over lipid-based amphotericin, while others seem to treat both choices as equally appropriate. And finally, also revise the antifungal therapy based on culture results, or if the patient fails to improve, after 48 hours. The very final thing I'll end this video series with is that you should not mess around with fungal infections, particularly deep opportunistic infections like Candida, Crypto, mucormycosis, and Aspergillus. These diseases can be tricky to diagnose, tricky to treat, and have high mortality. At least in conventional US practice, an ID consultation would be very strongly recommended in all of those diseases. That concludes this series on fungal diseases. I hope you found it interesting and useful. If you did, please share it with your classmates and colleagues, and consider checking out my similar series on antibiotics.